presentation of how. After that, we'll hear a short presentation on how wonderful TB community work is playing out in South Africa. And then we'll end with addressing your questions to our panelists. Now, you don't have to wait until the end of the panel discussion to enter your question into the chat box. You can enter it as it comes along, and I'll assemble them and ask them during Q&A time. So it's time for our opening remarks. It is my pleasure to introduce Professor Valerie Mizrahi, who is the former director of the Institute of Infectious Disease and Molecular Medicine at the University of Cape Town. Valerie's remarks will be around 5 minutes. Over to you, Valerie.
Thank you so much, Mia, and welcome to everybody who's joined today's webinar on such an important topic. Firstly, it's an absolute privilege to be sharing the panel together with such amazing women in celebration of National Women's Day, which is occurring on Saturday, but to discuss such a critically important topic. I am a tuberculosis researcher, and I've been in this field for some 3 decades. I want to start off my remarks by giving some context and really emphasizing and stressing the outsized contribution that South African researchers and scholars and public health specialists and advocates have played in the global fight against tuberculosis. We bat seriously above average in this field. And the question that I've been pondering is, why have we been able to make such massive contributions in the fight against TB? And I do think it's that sitting at the heart of this enterprise is a high degree of integration, collaboration, and coordination, where we are a community of people who work together to tackle the disease in an interdisciplinary way. So I see basic scientists, clinical researchers, and public health specialists in the academic sector collaborating and working across disciplines and working across boundaries with a unified vision of what we're trying to achieve. And we work together in the academic sector, together with people in civil society, with advocates, with community engagement experts, and very importantly, with government, which understands and supports the efforts that this enterprise has undertaken. Now, at the core of this type of integrated enterprise are women. And as we know, we coordinate, we cajole, we collaborate, we communicate, but very importantly, we lead. And when I think back over the last 3 decades, it's with a great deal of satisfaction and pride that I see the growing number of mid-career and early career women who are putting their hands up and saying, I am wanting to lead in a particular area of this problem. And you'll be hearing from some of these emerging and established research leaders during the course of today's webinar. When I was asked about 1.5 years ago, when I stepped down from my job of leading a big institute that had major programs in tuberculosis research, what I thought were some of the major barriers to progress in our field, I didn't hesitate before answering, resourcing is the #1 problem. We are limited and have been limited in the tuberculosis research and development field by chronic under-resourcing. This is in a field in which we've had not 1, but 2 United Nations high-level meetings to address the problem of tuberculosis, where participating countries made commitments to close the resourcing gap. We have never been able to close the resourcing gap. In fact, most recently, we are short by easily 80%. In other words, we're only achieving 20% of our targets. This is a very serious problem as far as I'm concerned, because it's limited our ability to think big, to act big, and to really achieve what we need to achieve, which is to get close to the end TB goals. I think the issue, unfortunately, has gotten a lot worse over the last 6 months. We have seen a withdrawal of overseas development assistance from the US, from countries in the global, other countries in the global north. exacerbated by changes in US federal funding policies, which are impacting the research and development enterprise of tuberculosis in a very profound way. But we cannot sit back and just accept that this is the way things are going to be. We need to sit as a community. We need to look at what our priorities are. We need to find much better ways to share information, to avoid duplication, and to double down on what it is that we need to do. And I want to commit myself personally to this mission, and together with the other women on this panel, to say this is our time to stand up and to lead, because there is no public health problem that is more severe and serious than the one that we're discussing today. Thank you, Mia. Over to you.
Thanks very much, Valerie, for that powerful opening remarks. And I love how you said we are seriously above average, despite being under-resourced by 80%. With that, I'm going to hand over to Lily, who's going to start off our panel discussion. To Lily.
Thank you so much, Mia. And Valerie, I remember yesterday we had a conversation and you said, you don't want to be referred to as prof. So thank you so much, Valerie. And I think what a strong end to your opening remarks to say that it is time to stand up and it is time to lead. And as you've said, we've got a phenomenal panel of women from across different disciplines and different spaces within the TB response and the TB various TB programs. And those women are Monica Longwe, and Monica Longwe is the social and behavioral change communications lead on the TB Technical Support Unit at Genesis Analytics. We've got Professor Lee Fairley, who from now on I will be referring to as Lee, who's a director at Maternal and Child Health at WITS RHI. Sbongile Chabalala, who's the national chairperson for the Treatment Action Campaign. We've got Anura David, who's the senior medical scientist at WITS Diagnostic Innovation Hub. And then we have Nandipa Titana, who's a community liaison officer for BPOT Yoluntu Center in South Africa. And what's really exciting, which Val already touched on already, is that these are women who are advocates in the space, that are in the policy space, that are basic researchers, that are working within community engagement, and they're going to share with us in this very interesting conversation that we're about to have exactly how they are leading and how they are standing up and how they've made this commitment to, against very trying times where funding is our challenges, where resources are challenging, what is it that we're doing? And we're honoring them today and spotlighting them today. And I'm going to kick us off with Monica. And I'm going to say, you know, Monica, at the center of any response to health are the people. And I would like you to just very briefly tell us what your work entails, what your work is about, but then also just highlight for us some of the examples where women and girls have been empowered through the TB social and behavioral change communication program. Thanks, Monica.
Thank you so much, Tuli. So like you rightly said, the communities are at the center of every public health intervention. So I work with the communities. I'm a social and behavior change communications specialist. That's my area of expertise. And as most of you already know, we're running the NTB campaign, the National NTB campaign, which was recently launched on World TB Day, by platform under which all TB communications are being implemented currently. So my role is to actually provide technical support and advice on the implementation of social and behavior change communications interventions. So in terms of how women are, we are trying very hard to make sure that all the interventions that we're implementing and designing are gender responsive. Just to highlight that when we say gender responsive, we're not excluding men. We are just making sure that we are considering the gender biases and the gender barriers. So we are making sure that women are being considered. We're making sure that we're looking at the needs of women and addressing that. And some of the ways in which we're doing it is to include women, to include the voices of women in co-creation. So the one thing that we've done on the insurance and materials with the communities, not just for the communities. And in doing this, in inviting the communities to the table, to the designs, to the workshops, we're not just looking at practitioners, but we're looking at the TB patients themselves, the healthcare workers, the caregivers, and we're also inviting them. I'll give an example of the platform that we recently developed and we're implementing under the NTB campaign. We've got the My TB Story that we launched last year. If you go there, you'll see that there are stories from TB patients, and I'm also happy to see at the beginning of the video because she's one of the people that we've been working with. We convened a message design workshop, and Solerwa was one of the people that she was telling us her experiences. So in the messages that we crafted from the message design, Zolerwa's experiences and messages are there representing the TB patients. So that's actually how we are involving not just the TB patients, but also the women in the space to make sure that we're reflecting the experiences of the women who've experienced it, but also the caregivers, just also to highlight that women are not just caregivers, but they are advocates of health, not just in the TB space, but in public health in general. So we are trying to make sure that we involve the women alongside the men, and we are considering their needs. Thank you, Ovara.
Thank you so much, Monica. It's, I love the word co-create because it almost tells us that you're really, because we like to say we leave no one behind, but often it's top-down approaches. So it's really cool to hear that you're working directly with communities and listening to their voices and highlighting their voices. And very quickly, these stories, you talk about the My TB story. Just very quickly, where is it? Where are these stories? The people that are in the audience, where can they go and see these stories? How do we reach them? How do we get to them?
So My TB Story is a web-based platform. It's on www.mytbstory.co.za.
Thank you.
You got that?
Thank you so much, Monica. Everyone in the audience, please go and check it out. I'm going to move now to clinical work, clinicians, and I'm going to go to Professor Lee Fairley, and I'm going to ask you, Lee, to just tell us very briefly, what does your work entail? And to what extent is it important to integrate TB and HIV and maternal child health in ways to improve health access services for women and children?
Thanks so much, and thanks for the opportunity to be on this wonderful panel. So my work, I'm actually a pediatrician by training, but currently mainly involved in clinical trials and implementation science research, with some clinical work. I think, integration. There are many examples of how integrated care can really improve outcomes across, the TB, HIV continuum, but also for maternal health, reduction in unplanned pregnancies, improved sexual and reproductive health, and HIV care. And, I think certainly I think sometimes though we don't always see the full impact in our daily clinical care. So I think a lot of the examples that we find are often around projects, and I think it's really a missed opportunity for us. I mean, we know that women and children enter the healthcare system at many time points. For example, potentially during a pregnancy, or then with maternal child follow-up at the EPI clinics. And I think we don't yet optimize those opportunities opportunities. I know there is a lot of work going on really looking at that. How do we improve, for example, maternal HIV care through EPI clinics, etc.? How do we improve TB screening, diagnosis, treatment, etc.? So I think it's really something that we do need to keep on our radar, but also just not to detract from the need that every interaction that somebody has with the healthcare system, it's an important opportunity to evaluate that woman and her child in the context of their society at large, what's happening at home, etc. And we really do need to put women and children at the forefront of their improved healthcare. So certainly we know that with TB, women are at greater risk of TB disease during their pregnancy and postpartum. I think it's an area that's not as well understood as we would like yet. For example, we don't know if it's mainly underlying TB infection, which then progresses, or new infection. But certainly we know that there is an increased risk. And we do also know that women are often left behind in research, in clinical care, often for good reason, around concerns initially about the safety of a drug or vaccine, for example. But unless we actually have a roadmap to including women and children in research and healthcare, we're actually not going to know what the optimized options are for them, how we can actually then look at, for example, campaigns around TB testing, or campaigns around hopefully if we get a TB vaccine in the next 5 years. So we really do need to be putting women and children front and center, thinking about how can we actually optimize our interactions so that they get comprehensive healthcare at each of those points, and particularly around HIV and TB diagnosis and care.
I like what you're saying about including them into research and including them into healthcare, because we heard from Monica how they interact and co-create with community. But from your perspective, in what ways do you think we could do that? Include them into research, include them into healthcare? And I'm asking for myself as a researcher myself in the HIV space, but how can we do that and put women in the forefront and how they inform the kind of research we conduct?
Well, I think, as was mentioned also by the first panelist, we also need to do this hand in glove with community, with stakeholders, with potential participants, because particularly in the research space, obviously people may have some concerns about the safety around enrolling in a study when they're pregnant, etc. And so we really do need to understand what people's concerns around that are, and really look at, how do we unpack that? How do we work together so that we can actually, develop research protocols or implementation science protocols where we're actually doing it together, where we're understanding where each other are coming from, and actually have a really strong proposal going forward. And I think a lot of it is around education. Certainly what we realize as we've been conducting some of these TB vaccine studies and various others is that people we assume that people understand TB, but as we saw in the video, there's still a lot of stigma around TB. There's a lot of, I think, lack of TB literacy, and so that's almost where we have to start. I think we also just need to look at every single interaction with the healthcare system as an opportunity. And I would say, in South Africa, certainly, I think on the HIV treatment side, I think things really run exceptionally well, and certainly I think on the TB side too, but I do think that we probably miss opportunities, for TB diagnosis, treatment, etc. I think also just to finally mention, I've been privileged to be part of a WHO committee really looking at how one can strengthen inclusion of women in research. So I was on the sort of vaccine side, but also for therapeutics. And I think what you realize, what becomes abundantly clear is that there is actually very little data, even on some of the therapeutics in pregnancy. And so certainly that leaves healthcare workers in a difficult position because they're uncertain around the safety aspects. Definitely leaves women in a difficult position having to decide about their treatment, etc. So we need a good roadmap, we need a good plan. Even if we can't include women right at the beginning, we need to have a plan for doing that and very actively work towards those goals. Thank
It
you.
sounds to me from just yourself and Monica that these components that you speak about may already be there. I think there might already be people communicating with women and while you're working in your space. And I think perhaps what would really be cool is to be able to see how that pathway can look following this conversation that we're having here that has so many different parts of the TB response system. I want to move on to Nandeep on the back of Lee talking about education, literacy, going into community. And I want Nandeep, if you can just come in, and very interesting that you were a translator in the court, so that's very interesting for me. And then now you're doing the work that you're doing at Be Part Yolundu. So please just tell us what your journey has been like. And how did you transition into community health? And how has the work that you've been doing at Be Part Yolundu help to bridge the gap between the health system and the communities that are affected by TB?
Good afternoon, everyone. This is Nandipa here from South Africa. Thank you very much for inviting me to the panels. I started working as an interpreter for social development in the local courts. So I would interpret from Xhosa to Afrikaans and then make it clear for the people at the court that they are very clear of what they're doing. So from there, I started volunteering with the social workers, and also I started developing the love of the community. I then worked in short programs in the Medical Research Council, and then I moved. There was then a space at Be Part Yolundu Center as a community development, as a community liaison officer. And then I saw an opportunity there to say, mostly they wanted someone that would lead the TB side. And I saw an opportunity to having grown in the very same community that we grew up with the stigma of TB, people not understanding the background of TB, people not going to the healthcare clinics to take their treatment and adhere for their treatment. So when I joined the organization, which is Be Part in 2023, I then saw the opportunity to have the close relationship with the clinic sisters, with the NOSA, TB contact, TB tracers, and the dot supporters workers, so that we can work closely, so that we can get the word on the ground on stigma, make it normalized, talking about TB, and making sure that people they adhere for their treatment, and also making sure that we share with the people the importance of taking the treatment of TB. So that is all from me, that side.
I like the idea of normalizing something to remove stigma. And you talk about the same community that I grew up in. Please tell us, what is that community and what's the reception been like in your route to working towards normalization?
Okay, the community, it's in Bekweni, in Paarl, South Africa, and which is the very same community that I've worked in. So for them, it's quite easy to adapt or to listen to the person that they know. So when you go out there in the clinic, when you stand up and try to share the importance of taking your treatment, so they make it quite easy to listen to you, and making sure that they ask questions where they do not understand, and also opening up their churches. If maybe they will put up an invite to say, can you come to our churches and explain more about the TB symptoms and about the TB treatment and the importance of taking your treatment. So it was the Mbekweni community, it's quite open in asking questions, and they are very quite open in learning more about TB.
Okay. My follow-up question for you, which you're not going to answer now, is going to be, how do we feedback that information back to the likes of Lee? who are in the research space. But that's going to be my question for you for my next round. And I'm going to move on now to Sibongile. While we're talking about community, and we're talking about women being at the forefront, raising their voices. And then we get to a point where we think about advocacy and the role that advocacy plays within combating and responding to TB programs. And I'm going to bring in Sibongile from the Treatment Action Campaign. And if Sibongile, you could tell us about your journey in advocating for quality TB, and if you can be also like very specific about how the community voices have directly influenced national TB policy.
Thank you very much, Tuli. I'm Sibongile Chabalala. I'm the National Chairperson of Treatment Action Campaign. I also want to declare that I was once diagnosed with TB in 2004. So I know very well when we're talking about TB, what we're talking about and how it feels as a woman to be tested for TB and what does it mean in our community. So, but I will focus more on the work that we are doing as an organization in terms of the of TB. As you all know that there's a synergy between HIV and TB, and mostly our members are people living with HIV, but you cannot separate HIV from TB. So it was very important for us to encourage women to understand on the ground why we need to know about TB. So we had a program that we call Treatment Literacy, where we were educating each other about the signs and symptoms of TB, what is the medication of TB that people need to take, especially women, because we are we are caregivers, and also we are mostly affected by these issues of TB and in our community. So there is a lot of challenges that women are facing in terms of addressing issues of TB. However, that pushed us in terms of advocating for policy change in terms of service provision in terms of TB. We were part of the, we led the court case, I think it was around 2008, 2009, of the guy who was in prison, who contracted TB in prison. And by taking that case, that Lily case, we were trying to influence policies in terms of how people who are in correctional services, not only male, but also women, are tested and screened for TB before they enter, because we know how TB it's been how is it spread. And also we were part of we led the march in 2021 of declaring TB as an emergency, knowing very well that was not going to be happening. It was our ambitious calls, but we were drawing attention to policymakers to say TB is killing more people than what COVID has done. And you have never responded like you are doing in COVID. Is it because it's killing mostly poor people, not people who have money and all those things? So we have worked so very much with government and communities in terms of addressing issues of TB, and also advocating for better drugs in terms of addressing MDR and XDR TB.
Wow. I remember yesterday you were saying that you make noise on the ground, and Sibongile, I'm starting to get the sense of how you make this noise on the ground, and it's such fantastic work, because I mean, if you've been able to get government on board, it means now you're working closer with government. Government is now hearing you, because the advocacy work that you're doing is so profound and it's so loud. I want to go back into the lab, and I want to bring in Anura. So Anura, rightfully, as basic scientists, I'm a basic scientist myself, we hardly find ourselves in conversations with people who work in community. You know, we often feel like we're a little bit on the margins, a little bit. So we know as well on the ground that we require faster, simpler TB tests. And we know that they're becoming more and more available. But I want to know what innovations are exciting for you? I know as researchers, we're very excitable people. So what are some of the innovations that are exciting for you, and how can they help transition access to diagnosis in especially underserved communities?
Great. Thanks, Tuli, and hello, everybody. Yeah, Tuli, thank you so much for inviting me to this discussion. As you mentioned, as laboratorians, we're often not part of these conversations, and we need to be. I think it's very easy when you receive a specimen in the lab, you're testing the specimen, you're getting a result out, but you don't think of the fact that, there's a person who at the end of this is waiting for that result, and this result is so important for that person's treatment and care. So, yeah, I've been working on TB diagnostics for over 15 years now. And I think that I was very lucky in one respect, in that when I started my career, we already had the gene expert technology. So this was a technology, it's a molecular technology, gives you a result within 2 hours, able to give you an upfront resistant result as well. And, previous to that, it was smear and culture that was mainly used for diagnosis. And sometimes it took weeks, even months to get drug susceptibility profile in order to get a person onto correct treatment. So I think that I'm very lucky. When I came on board, it was exciting. That was the technology that was only molecular technology that was available for quite a long time. But since then, we've made a lot of strides. Like since then, the WHO has made recommendations on moderate complexity technologies. So these are technologies that are more lab-based, highly centralized, high throughput testing. But then what we see in the last few years, where we seem to be going back and now realizing that high throughput technologies work, but they're not going to work in every setting, right? Different countries, different regions have different requirements. And I think it is really nice that the manufacturers especially are coming on board and saying that, hey, you know what, we know that there's not only centralized testing that's important, we need decentralized testing as well. So some of the newer technologies are now moving closer to what we call near point of care. So this is closer to patient, getting out a result quicker, simpler testing that can be performed by not necessarily a scientist in a lab. We also made some great strides in looking at non-sputum alternatives for everybody here. I'm sure everybody listening in, that sputum is difficult to produce in some populations, such as people living with HIV in pediatrics. And therefore, we've realized that, we actually need to start looking at additional specimen types. So when a sputum is not available, are there other specimen types that we can now use? So much of my research recently has been looking at an alternative specimen type called an oral swab. So it's a lot easier to collect. It is less invasive. We've also shown that it can be self-collected. So I think, there's been a lot going on in diagnostics and improving diagnostics in involving more patient-centered approaches. So truly, it's very exciting, definitely.
I like the idea of self-collected specimens, and I wonder, going back to Monica, if something like that would contribute to decreasing stigma, or maybe some kind of shame that might still be associated with contracting TB. So what, in addition to it, in your setting, Monica, what innovative strategies have you guys seen, or you guys implementing, that enable you guys to raise awareness and reduce stigma and improve TB treatment adherence, particularly in the community in the communities and the people that you work with?
Thanks to Lily. For us, innovation is not really much of the high-end, high-tech. For us, innovations means tapping into the strength of the communities. Of course, we're not completely ruling out the high-tech. Things like WhatsApp and other platforms are really very important. And also using AI to design some of the interventions. But in the communities, I think innovations really requires looking at the strength of the community itself. And I think you'll agree with me that considering the landscape, that is something that is very sustainable. So for us, some of the things that we consider as innovative are working with traditional health practitioners, like traditional health that we're trying to tap into. We recently had a workshop with the traditional healers to see how we can use those to actually test people, to strengthen case finding. Because when people get sick, in the rural areas, they go to the traditional healers. Usually they are a trusted source of help. They are healers. So we're trying to see how can we get the traditional healers to also support. We've got 3 pillars that we are trying to strengthen. So it's case finding, it's linkage to care and adherence. And also TB prevention. So we're trying to look at how can we integrate the traditional healers into the system and how can they support. I also talked about the My TB story. That's one innovation. So just to say that we're not completely rolling out tech, as you can see, we're also using that web-based platform. So we're integrating both the community and the, and the technological aspects of innovations. Maybe just to say a little bit about My TB story. It's a web-based platform that we recently developed, where it allows TB patients, their families, and healthcare workers to share their experiences. The idea is to raise awareness on TB, but also to inspire hope. It's mostly TB patients who've been through the treatment and they've successfully been cured. So they're sharing their experiences and encouraging others. Somewhere there is someone who's just been diagnosed and they don't know who to turn to. And they're thinking, oh, I'm dead. So the idea is that they can go, you don't always have someone to talk to you because you always want to listen to someone who's been through it, share their experiences, and then you get encouraged that if this person went through it and is now okay, I can do it as well. So that's the whole idea for people who have been diagnosed to actually get some support through that platform. So that's one of the innovations. And maybe just to mention one more innovation, we recently supported KZN to run an art competition for TB awareness in schools, in primary schools and high schools. So we got the learners to actually draw anything to do with TB, and like the ones that did very creative work won some materials, drawing materials, art materials. So 1,200 learners participated in that competition. And quite a number of people, like 300 learners and staff, were screened through that initiative. And then there were about 3 cases that were identified as TB cases, and they were linked to care. So you can see that's also an innovative strategy. So those are some of the things that we're doing. We've been doing a lot of things, TB champions. When we say TB champions, we're looking at the people who've been through the treatment, have been cured. So those are some of the innovations that we're doing in this space. And so far, so good.
That's so cool. I really do like the idea of including community to the point at which you're going to schools as well, and ensuring that it's starting at that young age where you're inculcating or removing a stigma or increasing your awareness of TB. That's incredible. And I want to go back to Lee, and I want to speak about resources. I mean, Valerie spoke about in her opening remarks resources and resource strains and constraints that have taken place recently, and of course, operating at 20% where the impact of responses are concerned. And I wonder if you can share with us some of the challenges that the resource limitations have brought into your work.
Thanks, Julie. And I think maybe probably just to speak about the broader kind of clinical and research community, I think, who have really all been quite severely impacted by some of the recent funding cuts. And, I think that certainly on the program side, I think that really is a big challenge. And we've seen some programs sort of just disappear completely almost, particularly around transgender people, men who have sex with men. So really concerning, I think people, there's a real concern that people are really falling out of care, not having access to treatment, which again, it feeds, if you're living with HIV, obviously that then increases your risks again of actually becoming diseased with TB, obviously, if you're not taking your antiretrovirals, your viral load will increase. There's a greater possibility that you could potentially transmit and obviously become ill yourself. And I think it's really from a programmatic point of view, there really has been a substantial blow to the South African treatment program. I think particularly where that has been affected is around the monitoring and evaluation of that program. So I think a lot of funding was really around collecting data for HIV, TB. Certainly, I think South Africa has a fantastic program, but really there was a substantial amount of support, which now has been lost. On the research side, I think also, really just to acknowledge, again, that the people have been through a very difficult time. Many people have lost funding. Many people have had to be retrenched. And of course, it kind of takes us, steps back from potential breakthroughs around, optimal treatment for both HIV, TB, maybe less in the TB vaccine space, but certainly HIV vaccine, etc. So, I think really just to acknowledge those challenges for everyone. I think that South Africans are resilient, and I think women are resilient, and we sort of think everybody is sort of clawing back and realizing that we really do need to be able to some extent stand on our own feet, but obviously, as researchers, we're entirely dependent on donor funding. But I think what it has done is really, make the community think about what, or perhaps reprioritize, think about, well, if we cannot get funding from particular areas, what do we need to do to actually make sure that important work remains funded? And some of that might require reprioritization. I think it really calls for increased collaboration, really across the spectrum, as we've discussed. So really thinking about including all relevant stakeholders, but also collaborations. I mean, for example, myself as a clinical trialist, I'll never be on the basic science side, but they're fantastic basic scientists in South Africa. And so really looking at how do we harness all of our energies together? How do we understand what the community needs, and make sure that the projects that we are planning to move forward are done so collaboratively, and that we apply for funding and other opportunities collaboratively.
And maybe we must also just reach out to some of the billionaires in the country to start providing more resources and being more involved. Sibongile, how do we activate South Africans who are resource affluent to be able to participate in the space? Is that something that's possible? Is that something that we can do? Sibongile, is that something that's already happening? As the full community, how do we get together to ensure that we're looking at local avenues for resources? Is that possible, Sibongile? Can we make noise on the ground?
I believe truly that is possible. It just needs us to come around the table and discuss and have a plan on how we are going to do this. I always say this. I believe that a private sector has a responsibility, a social responsibility into healthcare services, especially on the issues of TB, and especially when it also affects women and girls. I think there's a huge role that the private sector or the business or tap in the resources that are around, in the country, that can make a difference. We know for a fact that already in mines there is something that is happening, but we believe that it can go a long way if maybe we invite all the stakeholders on the table and have a discussion, an intensive discussion about TB and how it affects our life and how it affects the work that we've been doing as communities on the ground researchers and healthcare workers and how to try to deal with TB, because TB is something that is curable, and it's something that we all believe that it can be overcome but when we work together. So I believe that we can do that. It's possible, but it just needs us to be very strategic and have a national dialogue on the issues of TB.
A national dialogue on the issues of TB. Anura, while we're on funding, and of course the tools that you were speaking about are exciting. We want to use swabs instead of sputum to collect samples and put more control on the patient's hands. What would you say needs to change at a policy level or a funding level to ensure that innovations actually reach the patients on the ground? And also, I want to talk to you as a PhD student. How do you think the academic system could benefit from students having an understanding of how the research they conduct is meant for people on the ground?
Thanks for that, Tuli. So I think it's conversations like this. I really liked what Lee said about working more collaboratively. I think, especially in research, we tend to want to keep our studies to ourselves until our results are ready to publish, and that, I think, is not the right way to do things. I mean, especially with COVID, we saw that things changed. It was an emergency. We all were kind of forced to work together, and I think we had some lessons learned from that we can apply to TB and other diseases. Obviously, definitely working collaboratively. And I think that, like I said, when you were in the lab, you get a specimen, you would test it, and you don't think about the person who's actually going to get this result. You just want to get that result out. So I think we need to be part of more conversations like this, where you see the whole picture, not just what you're doing. So in fact, my PhD is looking at overcoming the barriers in the diagnostic pipeline. So looking at the diagnostics is just one aspect, and it's really opened my eyes to the fact that just collecting a sputum, our sputum rejection rate is so high getting before it gets to the labs. But why is that? Is it a problem at the clinic? Is it a problem with the patient? And we found that even sometimes it was just a specimen collection device, for example, that was problematic. It was the lid was not able to close properly, and there was sputum leakages, so there wasn't a specimen that got to the lab to be tested. So I think understanding the whole process, not just what you're doing in a silo, is extremely important. And I think that that is something that definitely needs to be focused on, especially as students. You focused on getting just your PhD or your research done, but then how are you? So when I'm going to graduate with my PhD, how am I going to use what I learned in my PhD to make a difference? How am I going to improve the quality of a person who has TB's life? So it's not just the academics and what you're doing, it needs to be looked at in a broader context. I think that's really important.
I love that awareness. I really do love that awareness. As a PhD student myself, I really do like that. And I think it is an important thing to think about, especially for us as future professors. We need to start thinking about how we filter that information of broader understanding of the research to the younger or early career researchers. I'm gonna go back now to Nandipa. Nandipa, I had promised that I want to understand how we feed back information to Anura as a basic scientist, as a basic researcher. As you can hear, Nandipa, it's a really important thing to understand, really, if you're working on the specimen, to understand its value chain, the route that it travels and how all of that takes place. So what strategies do you think we could use to feed info back from community to researchers?
I think it was Monica that mentioned earlier on about the testing where the participant can test themselves with the oral. testing. I think that one could help very much, because trying to think that some of the participants are staying in the rural areas. So it's quite a distance for the specimens to get to the site. Sometimes, as she mentioned, sometimes there will be just leakage and all of that. So going back to Monica's, think the self-testing of the oral testing, if that we can take that back and see if that could help us in reducing all of those issues that we now facing.
Landipa, I want to challenge us a little bit and say, beyond the collection of specimens, what are some of the other challenges that people are having on the ground, where it's information that needs to be looped back, where Anura doesn't necessarily have to be at the end of her PhD to figure out that, sure, I can't even test the sample because the lid wasn't put on properly, because we really don't know, that the clinicians don't know as much as you do. So that's the kind of open communication I'm talking about, to say to you, what kind of open conversations do we need to have, and how best could we introduce that? How best are we able to introduce a feedback loop of what's happening in the community into the, or must it go to the clinicians, to the nurses, and then the nurses must go to, how important is that, and how can we best achieve it?
Okay, firstly, I think having a close relationship with the TB nurses in the clinic, having to explain to them with the patients when they take the tubes back home, how should they be closed, and also going back to education, to all these open places, education and education and education, making sure that the messages go ahead to everyone in the churches, in the taxi rank, in an open space, to making sure that everyone gets the message. And also going back to the clinic nurses again, making sure that they teach people, or they direct people on how, when they putting the aspartams in the container, how do they put them and how to cough inside those cubicles. So I think it goes back to education and training also between us and the community research workers, and also with the clinic nurses at the TB clinics.
Someone suggested once that now and then basic researchers should go into community, even if it's just once, so that they get an understanding of, or a reminder of, who they're conducting their research for. What I'm going to do now is get closing remarks from everyone. Just 30 seconds to a minute of a closing remark, and I'll start with you, Monica.
Thanks, Tuli. I think the one thing that I wanted to talk about is how women are leading. We are currently supporting Gauteng with some work on laws to follow up. We recently had a meeting, and we had a HAS director who's, of course, also a woman. And I just saw how passionate she is about the project. And she kept on saying, we need to look at pregnant women in the TB program. We need to consider pregnant women. And that was very considerate, and it kept on coming up. So this is a woman thinking about another woman. And I think that is something that I saw passion, I saw compassion. And that's why I think this panel is very important, because women leading the TB response, I think we lead with compassion and we lead with passion. So thank you very much for inviting me to be part of this, and I really appreciate it. Thank you.
Thank you, Monica. Women thinking about other women and being considerate, compassionate. I like that. Women are leading. Lee, can we have your closing remarks?
Sure. So I think, just to say, I mean, tremendous progress has really been made, I think, over the kind of 3 to 4, well, probably more decades of HIV, and certainly there's been a lot of progress in the TB field, especially recently with a number of different vaccine candidates, moving closer, well, they're in phase 3 or kind of late phase 2 studies. different approaches to treatment. So, for example, shortened both treatment and prevention in inappropriate ways, new diagnostics. And so it's extremely exciting, but we do have to keep our eye on the ball. We need to remain focused. If we don't continue with a sort of comprehensive, collaborative approach, especially in these challenging times, there's a risk that we could really set ourselves back. And as I think everybody's raised, we're all passionate about this, and we really do need to commit ourselves to making sure that this progress is ongoing, that we don't slip behind, but we actually look at ways of even further improving TB and HIV care, particularly for women and children.
Thank you, Lee. We need to make sure that progress is ongoing. We need to keep our eye on the ball. Nandipa, I will have your closing remarks. Nandipa? I don't know if I've lost Nandipa.
Not at all.
Oh, okay, there you are.
Yes, I am. I believe that different ideas approach is required to maintain or even improve effectiveness on TB. And also, I think that we need to invest in training and capacity of building women. And I think at BPAT, we are still continue doing that, supporting our communities through widespread education and further to reduce the TB. And prevent therapy in preventing therapy in our communities.
I agree with you. We need to invest some more in capacitating women. I like that. Sibongile, your closing remarks.
My closing remarks, I want to say we can do this. We can win the fight against TB as women, and women can do it. Together we can do it. We have overcome so many challenges as women. We have carried so much burden, but we pull through, so we can do it again as women. We need each other more than ever. Thank you.
We pull through as women. We've done it before and we'll continue to do it, Sibongile. I do love that. It's so positive. And then Anura, your closing remarks.
Great, thanks. So, yeah, I think what I want to say is that, the funding cuts have affected us so badly. The whole healthcare sector has been affected. We all know we touched on it briefly. But what is also made just the layperson aware of the healthcare sector, TB, HIV, what a problem it is, and the amount of work that we are putting into actually helping us to overcome these issues that we experience. And I just come to think of, I had a conversation with the Uber driver, and he was so excited to hear, okay, you work in the healthcare sector. Oh my gosh, what do you do? And when I said to him, I work on diagnostics for TB, and this is what the TB problem is. And he's like, well, I had no idea. But now that, we know about the budget cuts, we're now aware of TB. I want to know more about it. I want to read more about it. So I think that was one positive thing that came out, the fact that lay people are now more aware of what a problem TB is. And then I think in relation to that, I just want to say that I look at all these different diagnostics and I can make recommendations on their use. But if the correct people are not listening to me, or the person who's actually going to make a decision as to which diagnostics is going to be implemented, if they're not aware of all of this work, then there's no point in my actually evaluating these diagnostics, right? So I think we need to get our message out there. These kinds of panel discussions, these kinds of forums where we actually get together and we tackle the problem from a holistic kind of an approach, and we get the message out there, is definitely going to make some kind of a difference going forward. And I think we're definitely moving in the right direction.
Some more science communication. Valerie, I have about 2 to 3 minutes for you. I actually think I'm already over time. So I have about 2 to 3 minutes for you to just give us a reflection on all of these points that have been made in this conversation.
Thanks. I think that there will be some of this will come out also in the Q&A. But my overall impression is that I've always felt that there's a difference between optimism and hope. And the difference is that optimism, it's easy to be optimistic. It doesn't require energy and effort. Hope requires courage. And what I'm hearing reflected in the voices of the women on this panel is an enormous amount of courage. It's absolutely essential at this moment that we do come together. I'm hearing a real clamor call for working together. I made a pitch at the beginning saying that I do think a defining feature of our system is that it is fairly integrated. I think we can do a whole lot better. I do feel that we've got to take much more advantage of an opportunity for intellectual spheres to be intersecting. It concerns me when I hear that basic scientists argue that basic scientists are just digging they're waiting to publish their papers and get their PhDs. I must say that my own experience has been quite different from that. As a basic scientist, I've found a way to transcend right across into public health. But it takes a lot of effort, it takes a lot of humility to actually sit around a table with people who come from spheres that you know nothing about, to acknowledge that you know nothing about them, and to try to learn from others and try to find a way to change the language that we use to speak about what we do. Many scientists and clinicians are tied up in their own language. We speak to each other in our own language. And by default, that is exclusive of others, particularly exclusive of the public. And so I do feel that, as you've pointed out, Tuli, science communication is crucial. I don't think we do nearly enough of it. And I think that we are going to be severely tested in the near term, because the only way in which we are going to unlock the kind of potential that we need coming from donors and funders is to make a very, very powerful case for the value proposition for tuberculosis. And I think that we've all got to think very deeply about what that is going to entail in a resource-limited setting where there are so many other competing priorities. We like to think that TB is it. It's not. It's part of an integrated suite of problems that this country and the continent is battling. But unless we can make a better case, and perhaps in response to one of the questions, I want to argue a little more clearly about this, the value proposition to me is absolutely central. And this has got to come from the entire enterprise, not just public health people, but all of us together have to contribute to that endeavor. But it's just been fabulous listening to these perspectives, and I certainly hope that our participants who have joined have really appreciated who they're listening to. Thanks.
Thank you so much, Valerie. I agree with you. I'm also quite stunned and quite fascinated by this conversation and what's coming out of it. I think I'm going to hand over to Nandipa again. So Nandipa, you will share with us a community case study presentation. So over to you, Nandipa. Nandipa, are you there?
Yes. Good afternoon, everyone. Sorry, as I've introduced myself earlier on, so I'll quickly go through my presentation that I've prepared earlier on. Having grown up in a community facing many health system challenges, I saw a first-hand limited knowledge and understanding TB negatively impacted in our lives. This became more personal when both my mom and my child were diagnosed with TB, and we had very limited information or support in our family and also in our broader community. This experience has motivated me to become part of the solution and inspired me to ensure that others in my community didn't have to go through the same confusion and fear. I joined the research organization in 2023, inspired by BPART close relationship with the local clinics and the community. BPART conducts research in TB and HIV amongst other local important illnesses. And we offer other programs, including after-hour clinics that caters for after-school kids and also the working class people that knocks off very late from work. So we cater for those people. And also, BPART community involvement, TB care nurses have noticed that TB stigma and vaccine hesitancy have reduced. People are more aware of TB symptoms and patients present earlier for TB. And women play important roles in the screening, detection, prevention, and treatment of TB. We are largely the caregivers in the community, taking family members to clinics and providing our children with their daily medication to prevent or treat. The local TB nurses that showcase their contribution to TB care, this includes the DOTS support workers, the NOSA contact tracers, and the community research workers of BPAT. DOT supporters and NOSA TB contact tracers go door to door in the community and form a deep relationship with people living with TB. This enables them to perform critical roles in TB care, encouraging patients to adhere to treatment. Number two, identify an individual and referring them for TB screening, and also finding TB contacts who may benefit from TB screening and further prevention. TB clinic nurses have identified few reasons why these women excel in these roles. As women, we are approachable and we enjoy forming relationship. Through our empathy, women understand the fears, loneliness, disappointment with TB. We can have we have clear, compassionate conversation that allow us to provide steadfast support for patient. Women are resistant and give hope, inspiring patients to persevere. As BPAT community research worker, I help to reduce the workload at the clinic by providing TB screening, contact tracing, and helping treatment defaulters to go back to their treatment. I also collaborate closely with the mobile clinics, faith-based organizations, and centers, youth centers, and also educate the schools, normalize the conversation. And also I conduct education in the churches, open fields, workshops, schools, tax errands, and also I educate stigma, encouraging for people to go for early testing so that they can get to treatment and adhere to treatment. So on this Women's Day, I celebrate the women of the community to improve TB care and their unique womanly ways. I applaud the TB nurses for their passionate care. And lastly, I would like to thank BPAT Research Center for empowering and supporting the community of Mbekweni. So that's all from me. Thank you very much. But I'm open for questions. Thank you.
Thank you so much, Nandipa, for that. I mean, we can just see the passion and the care and the excitement you have for the work that you do. And so thank you so much for the work that you do. I'm going to now hand over to Mia to conduct the Q&A for us. Thank you.
Thanks very much to Lily, and thanks for everyone for all their questions. We've had quite a few, so thank you so much, and it's a reflection on the great discussion that we just had. I wanted to start off with a short comment from David Nkana, who says sharing real stories from TB survivors can be highly effective as a strategy to encourage others to seek diagnosis and treatment, speaking from own experience. And he mentions that the personal narratives help humanize the disease, reduce stigma, and provide hope. And then refers to the TB Story project that Monica mentioned. So to move on to questions, the thing on everyone's mind is the impact of funding cuts on projects. And I'm going to start off with a question from a journalist, Kerry Cullinan from Health Policy Watch. She asks, I know it's still early days, but have any of the speakers noticed an impact on the funding cuts on TB testing and treatment? I wonder, Sibongile, you work at the Treatment Action Campaign on the ground, the people that you work with. Have your staff brought home messages specifically on the impact of TB testing and treatment in the field? What are you seeing?
Unfortunately, we do have a bit of data of what is happening. So in terms of service provision, there is more waiting time in clinics in terms of people who are getting services, and patients are getting slower services, although we understand that mostly of healthcare workers are trying very hard to deal with that. So numbers of TB testing, it has been reduced from the 300 facilities that we surveyed from April to June. Out of 8,317 patients, only 4,000 are saying have been surveyed, and over 3,000 they are saying they are not surveyed. So it could tell that even though it's still early, there is a bit of changes or service provision that it's going very slow in facilities in terms of TB. And also out of that 8,000, mostly or more than half of those patients have said that they have received a preventative therapy, and half of them they said no. So these are not good numbers that we can proudly say the service provision is going very well. So there is an impact in terms of funding cuts, although as she said, Kelly, it's still early days. We are still monitoring, but there are a bit of disruptions of services in terms of TB services provision.
Thanks very much, Sibongile, for that was great data. I'm going to move on to a question from Zambia, from another journalist from the Zambia Daily Mail, Monica Mayuni. And she asks, what realistic ways should South Africa and other African countries consider following the policy shift towards health support to most African countries? So where are we going to raise the necessary funds from? And I know that's not entirely clear yet, but discussions have happened around this. And I wonder, Valerie, would you like to respond to this? What do we need to look at? We've had some responses. We've heard about reprioritization, collaboration, asked the billionaires, where's the money? What is your advice, Valerie?
Okay, so thanks, Monica. I think this is a key question that is burning to all of us in the field. I would like to distinguish what we're looking for funding for, and I think that discovery and development of new interventions for better control of TB is the area that is the fair domain of tuberculosis research and development. I think it's important to distinguish that from the delivery of health services. They're of course both incredibly important, but the funding streams are inevitably different. So to put the former into perspective, TB research and development, 50% of global funding for tuberculosis research and development has come from two sources: the US National Institutes of Health and the Gates Foundation. We know that the US NIH now has undergone enormous change in their policy with respect to what they're going to fund and who they're going to fund and how they're going to distribute funding outside of the United States. This is putting a severe dent on the amount of funding that's going to be available for taking the very exciting scientific advances that are in our hands as we speak. Many of us would feel there has never been a better time for doing TB research and development than there is today. But it's taking that a little bit out of reach and forcing us to look inward as African countries and to actually take our seat at the table of responsibility for looking after this field. I was at a conference of TB drug discovery and development in Spain 2 weeks ago, and I've never seen more participation from colleagues from India, as well as colleagues from across the African continent. I sat with a few of them, and we agreed this is our time to put our hands up and to say we're no longer going to be secondary participants. We are going to play the major role in advancing this field. Now, what does this require? This requires our governments to understand and fully appreciate the importance of national investment in research and development. I think it's a sad admission of the state of affairs that South Africa still invests only 0.6% of its gross national product in research and development. This makes us the highest on the African continent, but it is a woefully under-resourced enterprise. So I think the first thing that we've got to admit and acknowledge, we have not really succeeded in making the case for why there is a direct relationship between investment in research and development and human development on the one hand, and economic development on the other hand. We have not done this successfully as a community. And I wonder why that is the problem, because the data are absolutely clear. Those countries that invest heavily in research and development, South Korea is a brilliant example. They accelerated their investment in research and development, and Mia, they did this at the expense of other forms of investment. They made choices. These countries made choices, and they reap the benefit decades later. So again, I feel that we've got to do a much better job of making the case for investment in research and development so that we can bring home and reduce our critical dependency on international funders and donors, where literally we go hand to mouth. And I feel that we are in many ways having a breakthrough. You would have seen that the South African Medical Research Council has been able to secure funding from the government. And this has been co-funded by the Gates Foundation and the Wellcome Trust to at least deal with the emergency crisis that we're facing of the grants, that research grants that have been cut. Now, others are much better qualified than me to talk about how we mobilize and make better use of national resources in the health budget to ensure that these gaps that have been cruelly exposed are not only closed, but that we start doing things a whole lot better, because ultimately we can get all the tools in the world for TB control. Unless we can deliver them in a fair, equitable, and efficient manner, they're not going to work. Thank you.
Thanks very much, Valerie. And talking about the extra money that the South African Medical Research Council got from the Gates and Foundation and Wellcome Trust, what I really liked about that was that it required buy-in from the government, that they were only getting money if the government gave a certain amount of money as well.
Indeed.
Let's move on to the next question.
I think that
Sorry, no, make your comment.
I think that's absolutely crucial to acknowledge that point. In many ways, it's almost sad that this needed to be a condition. But the fact is that the national government did come forward. The funds are available, and it's going to make, I think, a huge impact on those of us who are struggling with grants that have been cut. Thanks. Thank you.
Thanks, Valerie. Next question is from Bukti Beku, who is a DR-TB survivor who was diagnosed with TB while she was pregnant. She says, I would love the researchers to put more focus on protecting pregnant, lactating women and adolescents through research and recognizing and embrace and appreciate that the communities are experts of their care. She says we also need to involve TB survivors in design, implementation, and execution of research. I would like to ask Lee, are we doing enough of this?
Thanks very much for the point, and I think it is absolutely critical. And so perhaps just to kind of unpack the research in pregnant women and people is that it's obviously quite complicated, right? I mean, we would never want to do harm to either, to the woman while she's pregnant, the pregnancy, or to the infant, but there are definitely steps that can be implemented to actually safely include women in vaccine and treatment research. And there, as I think I briefly mentioned, we really need a proper clear plan at the beginning of any clinical trial that everybody agrees to. So, the sponsors, the manufacturers, everybody, and then mainly actually the community and people like yourself who have walked the walk and can talk around this to be involved in looking at studies and designing studies that really give us the information that we need. So I think the complexities come in, obviously with treatment, and it's been the same sort of argument with HIV, is that treatment, I think, is a little bit easier, because obviously if you've got TB disease, you need to be treated. The ethics of that are very simple. With prevention, it has to be probably a more phased approach, and we need to make sure that there's an element of safety data at least before we actually include pregnant women in research, and often, even on the treatment side, the research is almost accidental, if you will. Someone has been diagnosed with TB, they have to be on treatment, or they become pregnant while they're on their treatment, and often that does actually give us an opportunity to be able to really understand what's happening. So I think certainly, we have to be advocating for this from the beginning with our studies. We have to involve communities more, particularly people who have been personally affected, and certainly, the HIV PrEP studies have been very good at this, but I would have to say that many of the other studies are not, and so we really need to think about this engagement upfront. As I saw, you also had a question about short course TB treatment in children. Certainly there is research that's been done. The guidelines have actually switched now to uncomplicated TB in children, which is about 80% of children diagnosed with TB actually receive a short course regimen. More and more research around MDR TB regimens. So certainly the field has progressed and continues to progress. And again, we have to make sure that what's happening in research then gets translated into what's happening in the public health space. Thank you.
Thanks very much. Thanks very much, Lee. Before we move on to the next question, I would like to ask Nandipa to, in the chat conversation, respond to a question, because it's a lovely question for you. It is Mamote Makhoba asking, how do we get hold of you, Nandipa, to support you and the amazing work that you are doing? So maybe you can provide your contact details there. That's a nice thing to know, that people want to support you. To move on to the next question, we've basically got time for one more. And that is from Kekeletsu Kau, says, in the context of persistent patriarchy and rising gender-based violence in many African societies, what inclusive strategies can be implemented to support and increase women's participation in research, particularly research focused on TB care during and after pregnancy? Monica and Nandipa, you both work on the ground and you involve women and help to recruit participants often for research. Would you like to respond to this?
Yes, thank you very much. And when I saw that question, I was like, wow, someone is bringing up patriarchy, which is a real thing on the ground in many African contexts. And it's affecting a lot of public health issues, not just TB. And we talk to the communities. And when we're talking to the communities, we need to understand what the needs of the women are and what the barriers are. So we cannot just sit here and think that, okay, maybe they're being affected in this way. So we talk to them and with the civil society. So we were trying to design messages for the communities, but we cannot just design the messages for the communities. We have to do it with them. So we were developing personas. So we had like profiles of women, what kinds of women, blanket term. There are different types of, they're pregnant women, they're young women, they're different types of women. So we try to look at who is at risk more. So what kind of women are we looking at? And try to break it down to what are the needs, what are the barriers and everything. And then as we design messages at the community initiative, engagement part of it, but I think Lee is going to answer the research part of it. So we talk to them, we do research, we understand their needs and the barriers, and then we address it accordingly. Thank you.
Nandipa? Yeah, Nandipa, your mic is off.
Sorry for that. I believe that we need to collaborate with the government, the private sectors, and other organizations, and also to form some sort of some intervention group support that we can gather with all the women that we think that they might be in need of the information. So I think if we can gather all this organization and try to structure or form some groups that we can all gather together and try to talk about all these issues.
Thanks, Nandipa.
Thank you.
Before we go, Anura, before I hand over to Tulile, Anura, would you also like to respond to this?
Yeah, sure. So, yeah, we definitely need to create awareness. That's something that I totally agree with. And yeah, although I'm not on the ground, I have to say that learning from the community and involving people from the community, especially when designing our protocols, etc., is something that we definitely need to do. And yeah, definitely something that I'll take into consideration going forward. So thank you for that.
Lee, I can see you, your face looks like you want to respond, so please have the last say if that is the case.
No, I was just listening to everyone else's response, but I think it's what everybody said. But I think it's also continued engagement, and I think, meeting, really just understanding, who our community is, what they need from us, what their concerns are, and really, trying to. I think a lot of what women appreciate about being in research is actually the additional care and concern that they get. And certainly that shouldn't really be restricted to research. It should be, more universal. But I think really, kind of meeting the woman and the child and the family where they are and trying to optimize their care, I think is what people appreciate, and understanding that you're trying to the overall public health benefit of the research that we are conducting.
Thanks, Lee. And on that note, I'm handing over to Tulele to close for us.
Thank you so much. Thank you so much, Mia. And I think as I'm thinking about it, I'm thinking about the conversation we've had, and I'm thinking about the opening remarks, and I'm thinking about all of these questions that are now being posed, and listening to the level of positivity and willingness to help, and everybody's trying to find, where do I fit in, and how do I make it a better healthcare system? How do I contribute to TB awareness? How do I contribute to combating? How do I contribute from a therapeutics standpoint? And, I'm thinking about it, and I'm saying, even today, women are coming together for a cause. And that's what we're seeing in this call. And that's what we're hearing in this call. We're hearing that women are leading. We're hearing that women are courageous. We're hearing really positive messaging, in spite some of the challenges that we're facing today in combating TB, and some of the challenges that we're facing in the healthcare system holistically. And I think I'm certainly encouraged. I really am certainly as well really proud to be part of the system that's working on HIV and working in part of this challenge that is advancing healthcare in Africa, in South Africa, in the world. And I'm hearing a lot around communication. There's a big need for communication, communicating across sectors. There's a big need for use of language and understanding the language that we are using, regardless of what silo you are in. We should be able to communicate across, walk across the bridge, and be able to talk to and use the language of a community worker, use the language of an advocate, use the language of a policymaker, if that's whose attention we're trying to get. And I think that's coming out quite strongly for me. I do like also the call for the private sector to come on board that came out earlier, but also just a big call for collaboration. I think everybody agreed throughout the call that collaboration is going to be important moving forward. So I do want to say, I want to thank all of the speakers. You have been fantastic. You've been marvelous. Thank you, Mia, for co-moderating with me and running this ship with me. And I also want to just thank the organizers and to say that the call to action for this particular session and webinar that we've had today is to say we need to recognize, we need to invest in, and we need to support women-led TB efforts. But also, this conversation can't end here. We were hearing about the feedback loop of information and communication and creating awareness and making sure that we're sharing information as much as we can. So this conversation can't stop here. So please do go onto your social media platforms. Please tag Global Health Strategies. Please tag Health Policy Watch and ensure that this conversation is continuing. Again, my name is Thulile Kanyile. Thank you so much for joining us. Thank you again to the speakers. Please do enjoy the rest of your evening. And if you're in Johannesburg, stay warm.